Good morning. We will be starting our symposium. Thank you so much for coming to our presentation. We will be discussing a very important topic to our hearts: how to offer inclusive and whole-person gender-affirming care in perinatal substance use disorder treatment. My name is Vania Rudolf. I am the immediate president for the Washington Society of Addiction Medicine and the new chair of the International Society of Addiction Medicine group, Women and Addiction. I would like to start with a big heart for all of you being here. I have co-presenters. I have Taila, Adam, Tarek, and Carrie. We have no disclosures. And our learning objectives include discussing evidence, clinical guidelines for whole person and gender-affirming care, also integrating clinical utility of harm reduction into existing standards in clinical practice, emphasizing the importance of family support, legal support, and sharing with you about a very exciting service that exists in Washington, F.I.R.S.T Clinic, and discussing the importance of emotional intelligence and cultural humility when we foster safe and equitable gender-affirming care. When we look at this slide, we recognize that women remain underrepresented in treatment. This is a call to action. Pregnant and postpartum people with substance use disorder face on a daily basis a lot of barriers to care, a lot of stigma, and fragmented healthcare systems. Let's highlight the importance of clinical utility and harm reduction and how we can implement it in daily practices. People usually wonder, what is harm reduction? It is a patient-centered approach around the individual receiving treatment. Being able to meet people where they are, with compassion, with non-judgment. Being able to listen, to be present, to be mindful, to see the person. How we do this in Seattle and Washington State is by appreciating a service that allows people to be seen for who they are. Moms, women, birthing parents, parenting moms, to be able to feel safe and comfortable. I'd like to introduce the co-founders of the F.I.R.S.T Clinic who will be able to share with you about their work. Adam and Taila. Thank you.
Good morning, everyone. Thank you for being here. My name is Adam Ballout. I'm an attorney with the F.I.R.S.T Legal Clinic. Our clinic stands for Family Intervention Response to Stop Trauma. And the trauma that we've identified and that we're attempting to stop is the unnecessary separation of infants from their families at the hospital immediately following birth. The families that we're involved with are brought to the attention of the state due to concerns about substance use. In keeping with the theme of the conference, I'll present some numbers globally and then some of action taken locally for this situation and problem. In the United States right now, at any given point in time, there are 400,000 children who are in foster care. These are children who have been separated from their parents and are placed either with strangers or with family, but the key part is that they're separated from their families. And in the United States, the child welfare system exists as a punitive model for addressing issues. Just by a show of hands, in the countries in which you are, how many have systems or organizations in place in which the government can remove a child from their family based on concerns about substance use? Just by a show of hands. And those same hands raised, how many of those countries or systems allow for the termination of those rights by families? So a smaller number. In the United States, a termination of a parent's rights can occur at the end of the process. And what that means is a birth certificate, a new birth certificate is created. the prior parent is deleted and a new parent is added, the adoptive parent is added. And this creates not just trauma, but generational trauma, which is cyclical. And cyclical trauma, we've seen through our work, has the power of continuing. A third of the clients that we've helped grew up in foster care. And so really stopping that cyclical pattern of systemic reentry is what our work is truly about. We also saw disproportionate results between families that have money. Families of wealth in the United States never see the foster care system. Their families have entirely different outcomes. And oftentimes those outcomes can occur on the same day. The same mom giving birth, 4 different moms giving birth on the same day can have 4 different outcomes, just depending on the economic status of the family. And oftentimes in the United States, poverty can be conflated with abuse. So a family that doesn't have the resources or needs can actually be targeted by our child welfare system for observation, policing, and then have that child be removed from their care. And then an exorbitant amount of money spent on foster care systems and professional systems, propping these systems up. Ultimately, our work in the F.I.R.S.T Legal Clinic started as public defenders. Taila and I are public defenders. That means we are appointed by the state at the point of loss. At the point that a parent loses their rights, they're entitled to an attorney in the United States 3 days, 72 hours after that event has happened. And our belief was that that occurred way too late. Even if we went into court and won and had a child returned to the family, the trauma of separation had already occurred. The trauma of that removal had already started. The adverse childhood experience would follow that child and the family throughout the life of the family. It also makes families wary of opening up and asking for help. We have mandatory reporting laws in our country. By a show of hands, how many people are familiar with mandatory reporting laws where professionals are required, or they'll lose their license, to report? This creates scenarios in the medical system where doctors don't want to report because it also results in a family not coming in to seek prenatal care anymore, the loss of that relationship. So our work and our collaboration with partners like Dr. Rudolf, Dr. Vania, who I'm very honored to present with, allows for a report to be made, but then also for the family to be supported with legal supports and then the assistance of what's called a parent ally. A parent with lived experience that has been through the process before that can act as an emotional bridge for this parent to help them seek treatment, help them get the evaluations they need, and then if they need transportation or additional assistance, to get them into treatment, to facilitate getting over every barrier that may come up. The old model required the smashing apart of families before we all did this. And this process took years, and oftentimes families were never actually put back together. The process of breaking a family apart would result in a family not engaging. And Taila and I, for 18 years, would sit next to an empty chair in court where families had lost hope and had decided that they weren't even going to participate in the process because they've had a family or a child taken from them in the past, and the trauma, the tragedy, the loss of that led to a relapse or led to them not being able to stay in a loving and a clean environment. This is the current model that we operate in. Everything is siloed. And so in the opening speech and in the welcoming, we were talking about cross-disciplinary learning and cross-disciplinary pollination. That's what excites our clinic. The idea of coming here and speaking to multiple disciplines about this issue and collaborating about a new way and a new approach that we can organize ourselves, not through a siloed nature, but through a nature of collaboration. One where we facilitate learning and we facilitate education for our clients so that they're not making decisions made out of fear or born out of pressure or somebody threatening their children with removal, but the idea of collaboration and coming up with a plan months before Child Protective Services knocks on our client's hospital room door, enters their room, and then asks to see their baby and to see their child. The time in which a parent is holding their infant should not be the first time that they're presented with questions about what their plan is. Stopping the dominoes from coming down, that is the focus and the process of our work. intervening in a critical moment and providing our clients with help and resources. When our clients are in a state of crisis, they are not able to think clearly about what their plan is. And if they're homeless or they're not able to have their basic needs met, they're not able to create a plan for the future. So sitting down with them in a space of non-judgment, in a space of compassion, in a space of understanding, and coming up with a plan is what facilitates these families' change. And the change that we've seen has been tremendous and has led to new advocates in the work. The 17th mother that we helped in our clinic is now a parent ally with us. And we're seeing more and more families survive the process of the state looking at their family without entry into systems. The parent ally is a critical part of our work. They not just provide this emotional bridge with the family, but they also are in the room with us for all of the interviews that occur with the social worker. We can make sure that the appropriate questions are asked, that the appropriate information is conveyed, and that the medical expertise and the medical opinion of the team is expressed to Child Protective Services and to the agencies that are involved, so that there is a collaborative, multidisciplinary approach that's involved, and that everyone's space is respected, everyone's voice is heard, and the idea of separating an infant from a mother is becoming less and less common. Just by a show of hands, how many countries or jurisdictions is removal from a family considered a last resort, a measure of last resort? That is becoming more and more common in our jurisdiction too. It's shifting from an idea of being a punitive measure, where pain needs to be extracted from people in order to facilitate a change in their behavior, to an idea of a compassionate, trauma-informed model, where people are met where they are, and their backgrounds are understood, and their backgrounds of trauma, and the trauma that even a child welfare officer comes and brings, pounding on their door, knocking on their door, can bring up. Having an advocate next to you during that process can make all the difference between your child going into care or your child never meeting a system, your child ending up with family. I also want to do a special thank you to Dr. Glavinsky for working with us through secondary trauma, compassion, and burnout that we deal with. We deal with a lot of tragedy in our work. There can be a loss of life suddenly to a mother and their infant. And the idea of taking these emotional issues and these emotional hits that happen and still moving forward in the work is a product in large part due to reflective practice. And the idea of having a space where we can meet and collaborate with a doctor in a non-judgmental way to express some of the fears and some of the concerns that we have in our work and some of the emotional toll that we've undertaken. And in that space of reflection and non-judgment, we're able to do our work and move forward. And with that, I will turn it over to Taila, our Executive Director for the F.I.R.S.T Clinic. Thank you.
Good morning, everybody. Thank you so much for coming today. My name is Taila Ayay, and I am an attorney that works with Adam. I'm really pleased to be here, and I know that when we first started this work, a lot of questions that came up that we received was, why attorneys? Why you're only going to overcomplicate an already complicated system? Attorneys are aggressive and litigious, and we don't need them in this space. And the reason, which Adam touched on a little, that we recognized that it was important for us to be in this space is because of those hearings that he mentioned, those 72-hour hearings, 72 hours after a child had been removed from a parent. And we would meet with people who had just given birth that were absolutely broken. Their newborn baby had been taken from their arms, and they had no idea where they were at times. And we would ask them, we would read through what's called a petition that would lay out the allegations as to why this child was removed. And most of the time, the reasons were lack of prenatal care and inability to seek treatment for their substance use issues. And we would ask our clients, if given the opportunity right now, would you go to treatment? And every time they would say, yes, I didn't know that that was an option. I didn't know that that was something that was available to me. And so we recognized, after seeing this over and over again, watching families be completely destroyed, that if we moved upstream and if we started working with families and really giving them this opportunity that in our country is only available to the most wealthy of people, to have attorneys before a problem occurs, what would happen? And we were told, babies will die. You will kill babies because of this. And I'm pleased to say that that has not happened. And so there are so many reasons why pregnant people may not seek care, especially if they are actively using substances. They have a huge fear of losing their child. That usually is the biggest, most #1 fear. They don't want to go to a doctor because they don't want that doctor to report them. They have fear of legal repercussions. In our state, we're fortunate enough that using substances while pregnant is not a crime. However, there are other areas across the United States in which if you use substances while pregnant, you face prison time. And that is a criminal charge. We also have clients that have fear of losing their partner, that if they are seeking treatment or seeking help, that will mean that they will need to separate from their partner because their partner will not be able to receive the same help as them. And currently now, what is fairly new to our country is fear of deportation. That's something that is coming up recently. We have clients that are not seeking prenatal care, not seeking medical treatment for fear that their immigration status will result in them being deported from our country. And finally, it's the fear of the stigma and bias and the shame that they have for using while pregnant and just knowing how they've been treated in the past. And so what Adam and I are able to provide to our clients is a confidential space. What our clients tell us is entirely privileged and confidential. Not only can we not share that with anybody, but we will lose our license if we share information without our clients' permission. And so we don't have to chart information in case notes. We don't have to put things in medical files. And what that allows is for our clients to be completely and truly honest. And when they are able to be honest with us, then we're able to come up with a plan that fits their situation and their circumstance, and that can work for them. We also can give them advice and help guide them based on those honest conversations as to what are their goals, how do they want to get there, and based on what they're telling us, what can we do to help them? And so when a person feels fully, or when a person can be fully honest and feel safe and their needs become very clear, then we are able to guide them. We're able to guide them to medical professionals that we know will not shame them, that will provide them with whole person care and will give them the respect that they deserve. We're able to encourage them to seek prenatal care, to seek treatment, to do things that will be able to be helpful for them so that that baby that they're carrying can stay with them once it's born. And one of the other pieces that we're really able to do is, Adam showed those silos and the building of bridges, the systems and the bureaucracies that exist that our clients have to navigate in order to access the services that they need are complex and overly confusing. And we can help build those bridges. We help make those connections so that our clients are getting the support that they need prior to giving birth. And the other piece of information, or the other piece that we offer them is knowledge. Knowledge about what is currently going to happen, what is happening right now. We provide them with legal advice and legal advocacy. And when you understand your rights, when you understand what your responsibilities are, when you feel informed, that's power. That provides parents with empowerment that allows them to make informed decisions. It helps reduce fear and it helps reduce stress. And it allows clients to start to advocate for themselves. We try extremely hard at our clinic to meet clients where they're at, wherever that may be. So sometimes that could be at an encampment, sometimes it is in a hospital emergency room, it is at Dr. Rudolph's amazing clinic, or it's immediately after they've given birth. And we want to meet clients where they are in order to make this not only as easy as possible for them, but also to support their autonomy. We want patients and clients to feel like they have control of the decisions in their life, because so often when they get involved with these punitive systems, that ability to have control is stripped from them. And so we want clients to feel empowered to come up and develop their own roadmaps for wherever they're choosing to go with their families, with their lives. And by doing that, to become invested in their own plan, they're more likely to follow through. And by doing that, we also are helping resolve issues before they're escalating into a crisis, before it's resulting in a removal of a newborn from its family. And so we're so grateful to work with Dr. Rudolf and her team because they truly respect whole person care. They want to ensure that not only are their patients' medical issues being addressed, but that their issues that are outside of what's happening outside of the medical realm are also being addressed. A lot of our clients have significant legal issues, evictions, active warrants for their arrests. They are involved in domestic violence situations, sex trafficking situations, and we are able to help alleviate some of these issues and relieve some of that stress so that our clients are able to focus on their health and wellness and their stability. Adam spoke on it a little bit about adverse childhood experiences. By keeping families together, we're hoping for better outcomes for children. He mentioned that 1/3 of our clients were involved in the system themselves as children. So many of them were in foster care, their parents were in foster care, and they've lost other children to the child welfare system. And so our goal is to stop that trauma and to really create long-term outcomes that will continue to benefit families for generations to come. And so what we've seen by doing this work is higher level of engagement in prenatal care prior to delivery, reduced child welfare involvement. 83% of the families that we work with do not have a separation of their newborn following birth. And for those that are involved in the court system, most of the time we're able to keep those children with family. We're seeing higher engagement with SUD treatment and an increased connection to community. We try not only to connect families to direct supports, immediate supports, but we want to connect them to community support so that when our work is done, they still have support around them that can help. And so finally, I want to share Alicia's story, which she's graciously given me permission to do, that highlights the success of the work that we've done with Dr. Rudolf and her clinic. On December 23rd, 2023, my clean date, the day my son was born. What a date to remember. When I look back, I can hardly believe how far I've come. At 8.5 months pregnant, I was homeless and in active addiction. My plan was to give my child up for adoption, as I believed this would be the best thing for him. But then I gave birth to a baby boy, 7 pounds, 11 ounces. The only thing I knew at that moment was that I was going to love him until the day I died. If I had never been given the opportunity to be his mother, I don't believe my story would have been so beautiful. Today I am a proud mom, a woman who has fought, who has sacrificed, who has risen. I wake up every morning excited to go to work because I have a job I truly enjoy. My son and I live in a home that is ours, and just recently I was able to purchase an amazing vehicle, a symbol of independence, stability, and the road ahead. But perhaps one of my greatest victories that I hold dear is I graduated and completed an entire year of treatment and counseling, a journey of self-healing, self-reflection, and transformation. And while there were moments when doubt tried to creep in, I never walked this path alone. My village stood beside me. My attorneys, my doctors, my peer advocates, parent allies, counselors and treatment centers, and so many others. Their guidance, encouragement, and unwavering belief in me laid the foundation for the strength I needed to keep moving forward. The programs I became a part of did more than just help me survive. They prepared me for success. They molded me into the person who faced the fire and refused to back down, the person who saw obstacles and pushed through anyway, the person who embraced the second chance at life with everything I had in me. Today I look at my journey and feel nothing but gratitude and pride. I didn't just rebuild my life, I created a future full of possibility, stability, and joy. And that is what we hope to do, is to create many stories like Alicia's, and to have our clients have a future full of possibility, stability, and joy. Thank you.
Thank you, Adam and Taila. As we can see, harm reduction starts with creating a safe space, comfortable space for people with substance use disorder, to allow them to be seen for who they are so they can engage in treatment. How many of you work at a place that offers free legal service for birthing people with substance use disorder? I see a few hands. I also see a lot of people who might have raised their hands. So to all of you, and also to Adam and Taila, I would like, as a medical provider, to share the benefits from offering a service that is free for our patients, that allows collaboration, allows creating harm reduction space that makes miracles and allows people to believe in themselves, celebrates them for who they are. So I would like to give an applause for Adam and Taila and for their hard work. As a physician, I would like to talk a little bit more about medical management and how we offer choices and allow people to have a voice to be able to engage in treatment. Annually, in the United States, opiate use disorder impacts 2.5 million people. I do work in Seattle, where fentanyl has become the main substance and the main opiate, extremely lethal, extremely potent. And hospitalizations related to fentanyl and opiate use continue to increase. For the past 10, 15 years, we have been using fentanyl creeping up. We no longer see people using the tablets. We see people using the powder and the rock. How many of you are clinical providers who offer services to people who use fentanyl and also help with medical management? I see a lot of hands, so let's make this interactive. If we look at data in 2023, only 22% of adults receive treatment for medications for opiate use disorder. So hospitalizations create this amazing opportunity for us to get to know our patients, to be healers for them, and to meet them where they are. If we talk about birthing people, we can appreciate how fentanyl has continued to contribute to increase overdose rates, maternal mortality. and also sharp increase in healthcare expenditure. Now look at the data. The cost of not treating maternal mental health and substance use conditions is $32,000 per birthing parent-infant diet. And what is the total number? 14.2 billion nationally. Now all of us have an opportunity as medical providers to offer harm reduction, to allow people to believe that they have a voice and they have choices, what kind of treatment they would like to receive, how they can receive it, and how they can be appreciated and celebrated for who they are, so they can have content in their life, they can be healthy. One of the medications that we offer is methadone. For the past few years, at a national level, we have been working with SAMHSA, with ISAM, to standardize new clinical practices that show that split methadone dose is a way to treat people, especially birthing people with opiate use disorder, and how clinical outcomes are improved from split methadone dose that allow patients who stabilize to have a full-term pregnancy, to deliver, to have good outcomes, and to have newborns who do not go through withdrawal symptoms requiring NICU admissions. Now, in the audience here, we have the new president for ISAM, and thanks to Dr. Taylor, we have continued to advance our practices. How many of you offer split methadone dose to your patients? I see a lot of hands. Thank you so much for your hard work. How many of you, when they stabilize patients in the hospital, offer 72-hour dispensing up to 3 days, allowing patients to discharge with dispensed methadone that will help them be set up for success and continue engagement in an OTP service? Okay. I see a few hands. I also see a lot of you who did not raise your hand. So here we have an opportunity to learn from each other. We talked how harm reduction offers free healing that is free of judgment, free of stigma, and free of bias. I'd like to share with you our protocol for split methadone dose when we see a person who comes to triage or to the hospital, any person of any gender. We start with 30 milligrams as a low dose with allowing as needed doses. Day 2, 30 milligrams twice daily with as needed doses. Day 3, 40 milligrams, then 50 milligrams. By day 5, people feel stable on their dose. And sometimes fentanyl contributes to very intense withdrawal symptoms that do require, in addition to methadone, to offer supportive meds and even short-acting opioid for a few days, such as hydromorphone. And as you can see here, the supportive meds that we offer are 4 medications that are non-opiate medications. They do not compete with the mu receptor and other opioids. They are tizanidine, hydroxyzine, gabapentin, and Vistaril, and dicyclomine bentyl. And they do help people feel alleviation from very frustrating opioid withdrawal symptoms. The protocol has been working so well, we are in the process of publishing it. I also would like to share with you the first data that we have from a clinical pathway we created that allows us to stabilize people in a rapid high-dose methadone way and also offer 72-hour dispensing in addition to harm reduction, including dispensed methadone, dispensed in a free methadone lockbox, also offering people to take free Narcan kit, making sure that we coordinate an OTP and methadone intake and a follow-up. For 14 months since we established the clinical pathway, we had a total of 79 people who completed the pathway. When we gave the choice of split methadone dose versus once daily dose, almost everyone, 78 people, chose split dose. There was one person who did not believe that their OTP will allow split methadone dose, fearing that they will be treated with bias and judgment. The doses at hospital discharge ranged between 35 milligrams twice daily to 210 milligrams twice daily. This is a total of 420 milligrams daily. We can appreciate the intensity of fentanyl, synthetic opioid, and especially the powder, requiring much higher doses. On average now, people who use fentanyl require up to 100 to 140 milligrams twice daily. This is the most common daily dose that usually we stabilize patients on. Everyone chose 72-hour dispensed methadone. Everyone received it in a free methadone lockbox. There were no oversedation, respiratory depression. People who discharged after that did not present to the ER with an overdose. They appreciated being trusted. They were very responsible with taking their methadone, and also the medication was safe when we were able to offer a free methadone lockbox. All of the people delivered full-term babies. Now, the program is also very financially feasible. As you can see here, the 72-hour dispensing led to 135-day reduction in additive hospital stay. So we saved a lot of money. We also allowed much more people to come to the hospital earlier so we can offer that treatment to more patients. Harm reduction also starts with offering free education to health professionals, all of us being able to learn from each other, to share experience. And last year, we offered a national summit that was free for all health professionals. We offered free nourishment, free CME, free education, free hotel, lodging. And I see some of you being surprised. We also did a survey that showed that all of the people, all of the health professionals, social workers, F.I.R.S.T Clinic, who helped us organize it, everyone who attended was so happy and felt invigorated and empowered from the collaborative approach. We were able to improve stigma, compassion, knowledge, education, comfort level of care, and attitudes to substance use disorder. So this is a really good way to empower all of us how we can create clinical pathways and to learn from each other. And as you can see, this beautiful art was actually created by Adam. I also would like to share the voice of a person with living experience who completed the pathway, who felt safe, who felt appreciated, who was able to get stable, to receive her methadone. She was able to stay with her family for 3 days, and every day I would call her. We will have a virtual follow-up, and we will talk how she was doing. And she delivered a healthy baby, and her baby did not require any treatment for neonatal withdrawal. And she shared, I have a much better chance to have a healthy baby, and she did. Another medication that we offer is buprenorphine. We have created unique protocols for low-dose buprenorphine initiation, recognizing that fentanyl contributes to a big intensity in withdrawal symptoms. If we offer a high-dose buprenorphine, especially for birthing people, it can make people feel very sick and contributes to vulnerability, and sometimes people would not want to continue buprenorphine. So this is a really good protocol that has allowed us to avoid completely any precipitous or high withdrawal scores, and has helped people transition and stabilize within 3 to 5 days. How many of you offer buprenorphine as treatment to your patients? Now, let's give each other a big applause, okay? Offering choices, offering medications, appreciating buprenorphine equally as an evidence-based medication helps people feel safe, feel comfortable, and helps them engage in treatment. As you can see here, the product, yes, I see a hand. Of miscarriage? Well, thank you for asking the question. I have been practicing in this field for almost 20 years, and I have not had a patient who has had a miscarriage from initiating buprenorphine. I also know that sometimes the intensity of withdrawal symptoms, especially in early gestational age, there is a risk for miscarriage, and data shows that in the first trimester, okay, any woman who has pregnancy has more than 50% chance of miscarrying, okay, whether you have any disease or not, okay. We also know that opioid use disorder can contribute to withdrawal symptoms for increased risk, which also allows us to appreciate how we treat opioid withdrawal to help people feel safe and to transition. Does that answer the question? Yes, please.
Just by, okay, we know that they can miscarry, but we are increasing the chance of miscarrying. With methadone, you don't have this risk. That's why we always opt for, if you're going to initiate treatment, safer is definitely methadone. That is what we believe. I've been treating patients for 30 years, so that's why I'm saying this. So patients who just stop using heroin or whatever they're using miscarry. Within 72 hours, they miscarry. So you have to give something immediately, otherwise it doesn't happen. If you have, if this is a way that you are preventing miscarriage, it's very interesting.
Well, so this is a good way for all of us to interact, okay? I really appreciate the conversation and I appreciate the question. What I hear from the audience is that not treating opioid withdrawal after 72 hours increases the chance for miscarriage. I also hear that people who stabilize on methadone due to methadone being a full agonist have no risk or maybe a small risk of miscarriage compared to buprenorphine. And data does and evidence show that people who engage in any medication for opioid use disorder have a better chance not to have a miscarriage. So I would like for us to focus on how medications for opioid use disorder help people get stable because they discontinue fentanyl. A lot of times synthetic opioids or heroin are mixed with a lot of adulterants that have a much higher chance from contributing to miscarriage. And also being able to treat opioid withdrawal in a way that the person continues to tolerate the treatment decreases the chance. There's also really good data to show that birthing people who stabilize on buprenorphine or methadone tolerate opioid withdrawal and treatment and in a really good way. And again, I have not experienced people going through miscarriage when we offer opioid withdrawal treatment and stabilization with both buprenorphine or methadone. So thank you for sharing. We also have a peer support line, which is a phone line. It is called Yes We Can. It is 833-937-9326. That is connected for all of you and offered. It is a free line. If you would like to, if you have any questions, feel free to reach out. It's also connected to me, and sometimes I answer it. And we would like to make sure that all of us work together and support each other. We talked about medical stabilization. We talked about legal services. I'd like to finish by sharing an innovative motto that we created, which is called compassion. It stands for Community of Maternal Parenting Support for Substance-Impacted People and Newborns. Beautiful, isn't it? Compassion is valued by all of us, especially by birthing people who deliver at the hospital. It is a 5-day extended postpartum floor stay that allows the parent, the mom, the birthing person, the newborn, the family members, the doula, the recovery coaches, to be together on the postpartum floor, where you have nursing continuity, medical provider continuity. You have the F.I.R.S.T Clinic being able to offer full support. You have lactation, doula support. You allow yourself as a medical provider to stabilize or continue medications, to address medical complications in any ways that are needed, while also empowering birthing parents to be educated, to be offered resources and tools how they can take care of their newborns. And you offer care to the whole family unit. So it does promote trauma-responsive, culturally sensitive approach that celebrates patients, allows them to believe in themselves, creates beautiful new beginnings for themselves and their families. We also have some data that shows that people who were treated with methadone and buprenorphine, who completed the Compassion 5-day stay, were able to discharge from the hospital with their babies, were able to go to treatment if that was needed, and everyone completed the 5-day stay. There was only one parent who fled the hospital the first day after social work made them feel very vulnerable and traumatized. So this is a really good way for us to appreciate the opportunity to create a safe space for the full family unit, and to decrease NICU admissions, to decrease neonatal withdrawal requiring pharmacotherapy, and to allow the whole family unit to stay together while avoiding foster placement and legal repercussions. Thank you so much, and I would like to continue now by introducing Dr. Tarek Haidar, who will talk with us a little bit more what happens once the birthing parent discharges from the hospital. Thank you.
Hello, my name is Tarek Haidar. I'm an addiction medicine physician, currently a medical director for a tribal opioid treatment program in Tacoma, Washington. I'm happy to be here. Thank you for being here. Since Dr. Rudolf mentioned about methadone and buprenorphine, so I'm going to touch base regarding pharmacology for both of these medications. We'll start first with methadone. Methadone, as you know, is a full agonist. It basically binds to the mu receptor, and which helps with analgesia, euphoria, sedation. We should also not forget that it's an MDA receptor antagonist, meaning that could help also with pain management. Usually with methadone, we try to pay attention to certain things, such as QT prolongation, over-sedation, especially with alcohol or benzo. In addition to the fact that we also worry about interaction with other medications that are metabolized by the same group of enzymes, which is basically CYP450, mainly the 3A4 and the 2B6. not sure what happened. Could people hear me okay? It's working? Okay, perfect. Now we're going to move on to the next slides. I remember one time during my fellowship days, my fellowship program director, Dr. Jim Walsh, who was a very wise man, told me that when patients are on methadone, they would like to, whenever they are on methadone, they would like to have a higher dose of methadone. And whenever they are on Suboxone, they can't wait till they get rid of the Suboxone. So today we're going to talk also about methadone dosing, which I find is quite an art, but art could be abstract. So some guidance would be helpful. What guides me usually through methadone dosing? A patient comes to my clinic, would like a methadone. If appropriate, we start on methadone. And at the dispensary, we keep adjusting the dose. But I can't keep adjusting the dose. There are certain things that I should keep in consideration. What are these things? So the guidance that I usually try to follow is one of them, three kind of guidelines, but one of them is basically trough level. So we know that methadone peaks between 2 to 4 hours, and the level declines afterwards in the next 24 hours to reach a trough level. Certain studies showed that a trough level of 400 nanogram over milliliter has been effective so far as a stable methadone dose. I haven't seen that in my practice so far. I see it more between 600 and 700 to be a stable trough level. We're going to talk more about what I've seen with some of my patients in later slides. Another criteria regarding methadone guidance is peak to trough level. I don't rely on it much often, but it's out there. Basically, they measure the ratio between the peak to trough level. The magic number is 2. If it's above 2, meaning that the patient is rapid metabolizer, they could benefit basically from a higher level of methadone. If it's less than 1.3, meaning a slow metabolizer, so we need not to adjust the methadone dose much often. Now another one I really like is basically before we go to this slide, is basically the metabolizer type. So there's certain metabolizers, and how do you differentiate between them? It's basically a ratio. It's methadone to the methadone metabolite ratio. The methadone metabolite would be basically EDDP. So that ratio, we usually plug it into an equation which show you if the patient is slow metabolizer, normal metabolizer, or what we call extensive metabolizer, or a rapid metabolizer or ultra-rapid metabolizer. Now, based on this, and I'm not sure how I could lower, pardon. Is there any way I could lower the slide? I'm not sure. Yes. Okay, well, I'm just gonna, sorry for the fact that doesn't show the entire slide. But at my clinic, we did a retrospective study. We looked at patients who did trough level and for 3 months, basically December, January, and February, in order to see how the trough level / metabolizer type has been effective in guiding our treatment. These patients were 26 patients, not many. 14 patients were male and 10 patients were female. None of these patients were pregnant. We did the trough level on them and the metabolizer type, and it shows that most of the cases, these patients basically, the methadone dose helped us, or the trough level helped us adjusting the dose afterwards. There are some exceptions to the case, and I will discuss with you after. But just to give you some background, in my clinic, we do a trough level at the dose of 150. I'm not sure what you guys do in other clinics, but 150 most of the time. Except if some patient has been on a stable dose of methadone, and this is when we try to do, and suddenly they ask for more or higher dose of methadone. This is when we also do a trough level earlier. Of course, we keep in mind the self-inducing effect of methadone, especially with the enzyme the 3A4. In addition to the fact that sometimes we do it for these patients, we do the earlier trough level for patients who have been maybe their age is in their 70s, 80s, elderly population. We're worried about sedation. In this case, we do the trough level earlier if they're asking for a higher methadone dose, even though they're not at 150. The other scenario when we do a trough level earlier than 150 is when they're basically on alcohol or benzo, and we're worried if we go up on the methadone level, that would cause oversedation. So looking at these data, sadly you can't see the lower part of the slide, but I could tell you that most of the case the methadone dose got adjusted based on the metabolizer type and the trough level. However, there was an early case where the methadone was basically trough is low, but the patient is rapid metabolizer. You would think that we would adjust it higher. However, the patient decided to switch to bup after, and they did not want a higher level of methadone. Another situation here, two other situations, two patients with high trough level, basically in the 1,000. However, there's no sedation in either of them. One of them was 1,300, and that patient was having a pancreatic cancer, and we ended up switching care to palliative. Now the other patient who also was a slow metabolizer with a 1,000 level, again, no sedation. The patient, however, got incarcerated, and the methadone dose got lowered in the jail system through an addiction medicine physician at the jail. So overall, that study helped us gain more insight towards how trough level is actually helpful in these patients. Now, we talked about methadone. Now we're going to talk about bup. Bup is a partial agonist. It basically binds to the mu receptor and has a higher affinity to the receptor that kicks other opioids that are bound to the receptor, which means that we have a ceiling effect, especially in terms of sedation and in terms of respiratory depression. Things to mind about bup. Bup has naloxone in it. However, the patients don't know it much, but providers know that the naloxone part is basically effective when we do it as intranasal or IV, more than sublingual. The cool thing about Suboxone that it basically exists in injectable, and there's a first generation, second generation injectable. Now the first generation, there's a new study now about the first generation injectable that you could do rapid initiation with the first generation injectable. In the past, we used to wait for a week of Suboxone sublingual before we start on the first generation injectable. Now you could do it on the same day after a small dose of the sublingual. In addition to this, the new study also showed other places where you could inject the first generation injectable. It used to be only in the abdomen, now in the glute, behind, on the arm as well, and they only came up with this study quite recently. What I like about injectable is the fact that they work as an auto taper. So you remember early when I was talking that sometimes patients who are on bup, at some point they would like to taper off the bup, and I find the injectable to be one of the smooth ways to get off bup. So an interesting study I found that was published in 2022. It's also a retrospective study that happened in Boston in an outpatient setting. 4 patients were retrospective study on 4 patients, so not many patients, but quite interesting cases. All of them they were stabilized on the sublingual Suboxone, and most of them they were on the Suboxone for actually years. As you can see, there's one 5 years, another one 4 years, and the dose ranged between 8 milligram once a day, twice a day, or 3 times a day. They all wanted to taper off Suboxone, so they transitioned them basically to the first injection Suboxone, first injection of the bup. Or I meant first generation, sorry. First generation of the bup. Many of them received this injectable for many times. At the beginning, 2 of the 300, and then they continued on the 100. Now later in the process, they all decided to stop the injectable. In that study, they noticed that withdrawal symptoms started to occur around 6 weeks after the discontinuation of the first generation injectable, and they treated these withdrawal symptoms with ancillary medications, meaning gabapentin, hydroxyzine, muscle relaxant, and that helps with these symptoms. Out of the 4, 3 of them managed to continue to be away from the BUP, basically following the discontinuation, and they did not report any illicit opioid use. Now, I'm saying they did not report any illicit opioid use because we're not sure exactly if that was the case, because there's only one who had urine done that showed no opioids. The other ones, they did not continue with monitoring their urine after. Now, out of the 4, one of them basically returned to use for a short period of time, and they stabilized that patient again on sublingual for a couple of weeks, and then they switched to a first-generation injectable for a few injections, and then that patient managed to stay abstinent. The thing that they found in the study that basically the BUP continued to be in the urine for 8 months following the discontinuation of the injectable. And for multiple follow-ups, patients did not show a craving, they were doing fine in their normal setting without return to any illicit use. Thank you so much. I'm going to pass it to Dr. Griffin, or Vania first. Appreciate your help.
Thank you, Dr. Tarek. We would like to continue focusing on emotional intelligence and cultural humility. And it is my pleasure to introduce Dr. Carrie Griffin, who is family medicine and addiction medicine physician, also offers OB services and delivers birthing people with substance use disorder. She is a person who is trained in trauma responsive care and who started Center for Growth. And she will be able to talk and inspire us a little bit more by recognizing the importance of inclusive, safe, and equitable, sexually diverse, and gender-affirming care. Thank you.
All right, we're at the hour mark and everyone is still here. So I'm curious, how many people here are perinatal substance use people? Is that a lot of, okay, I was getting the sense that some people that really is the ballywick, that's what you do, and for others that may not be the case. So you've probably gathered at this point that we're a little bit of a special populations group, right? So we've brought in the justice system. We have talked about how do we provide the best kind of medication-assisted therapy for opioid use disorder in pregnancy. I acknowledge I'm going to niche that down even further to talk about queer identities and gender diverse identities in pregnancy and people with substance use disorders. So a quote from Gabor Mate, who is I like to note, a family physician and an addiction medicine physician from Canada. Safety is not the absence of threat. It is the presence of connection. So what we are doing at a summit like this is we're taking time to connect with each other. And as we fill our own cups with that kind of connection, that's what allows us to go back and really be in service of people by being in connection and building and breeding that kind of response in our patient encounters. So one of the things that I've so valued about working and collaborating with Dr. Rudolf is she really has these 2 pillars that are part of her own practice, which she's added here, emotional intelligence and cultural humility. I would like to add even beyond cultural humility, which is something we're all practicing here as we learn from each other, as we cross cultural divides, structural humility. So what does it mean to actually be aware of the ways that the justice system, that transportation, that the way that food is delivered within a system, how all of that affects the care of our patients is incredibly valuable as we're working with a person in a one-on-one context. So let's define the letters, because often people get a little bit frozen when they see the big alphabet soup, as it is sometimes called. But the wide phrase LGBTQIA+ refers to people who are lesbian, so women who are sexually attracted to other women. People who are gay, so people who identify as being sexually attracted to people who are of the same identified gender as themselves. people who are bisexual or sexually fluid, people who are sexually attracted to people of either gender. What this acronym doesn't do is include some of the terms that are not actually that new, but have developed into the curriculum or the general conversation now, such as pansexual, so being attracted to people of any sexuality or any gender. People who are transgender, meaning that the sexual organs they were born with, they don't identify as the gender commonly affiliated with that, but they identify with the opposite gender. And I do love, for all the physicians or the medical people in the room, cis and trans, right? This came from chemistry, this actual little bit of nomenclature. Q, queer. So queer is often used, and it's really been a term that has been taken back, right? It's something that the homosexual community has taken back on and said, no, queer is not a slur. Queer is something that we're proud of. We want to name that and name it as something that allows us to be proud of our identities. It can also mean questioning. And one of the things that's happening as there's more public conversation about sexual identity, about gender identity, is people are often questioning later in life. So there's more and more people who may be identified as heterosexual, maybe entered into a heterosexual monogamous marriage, and then as they age, as they get to know themselves better, perhaps as certain layers of cultural trauma are digested and transformed, they find that they actually identify as queer. So questioning is something that it's worth us holding in our awareness as we're working with people across the lifespan. Intersex. So intersex refers to a lot of different conditions, but essentially it refers to people who are born with organs that don't match the classic chromosomal description of being XX, or born as a woman, or XY, born as a male. This can include things like Klinefelter's, like Turner syndrome, congenital adrenal hyperplasia, so it's a wide variety. If you ever want to go down an interesting rabbit hole around bizarre things that happened in medical history not that long ago, look at some of the history of how we used to treat intersex individuals. Look at the way that they had a gender foisted upon them at birth, which we now know can lead to a lot of struggle and suffering, and this was often hidden from people for years. Asexual or ally. And then plus refers to the panoply of other identities that you could have. One of them for indigenous, some of the work I do is in tribal health in rural Northern California, would include terms like two-spirit. So certain tribes already have the idea that there are people who are born with both genders as part of their soul. So there are no quizzes on that, but just recognizing that the letters aren't that hard to understand. But it can feel overwhelming. It's a lot all at once. It's like the cranial nerves all over again. So let's bust a few myths. Sexual orientation is not sexual identity. So what does that mean? Sexual orientation is an internal experience. This is your relationship to the erotic, to what actually excites you, to what creates a sexual turn-on. That may not be your public-facing identity. So recognizing, and again, thinking about that cue, right? More and more people may be questioning. Often, there's a beautiful book that was published only in 2008 called Sexual Fluidity by a Harvard sexual researcher. And it's a wonderful book. If you're curious about these topics, I highly recommend it. But part of what we're discovering is that many more people identify as fluid than we would have thought, or really than certain cultures and structures would have allowed us to imagine. Gender identity is not sexual identity. So if I identify as a woman, that doesn't mean that I'm only attracted to women. This seems obvious, but we're parsing it out because it can get a little gray and a little fluid. The other thing that's important, and particularly for this conversation where we're working with perinatal substance use, is that neither your sexual or your gender identity has anything to do with your desire to parent. And there is a little bit of a conventional wisdom or a default way of thinking that the heteronormative way involves what can often be termed to as breeders. Maybe people have heard this term, right? So heterosexual people getting together, making families, and gross, ooh, queer people would never want that. Well, that's too black and white. Right? And we're people who practice with substance use disorders. We are comfortable with ambiguity and ambivalence in a way that a lot of practitioners aren't. And so I would invite you to offer that same kind of penetrance-based thinking to gender and sexual identity issues. So this is actually a quote from the first trans pregnant person that I took care of, now about 6 years ago. So he was 20 years old, and I met him because he showed up in triage at 28 weeks having a panic attack, just full-blown panic attack, thought the baby was dead. I mean, just utter, and I just happened to be on the floor, so they grabbed me in the triage room. And what had actually happened, and why this person was having a panic attack, is they started to Google cannabis use in pregnancy. And I'm from a part of rural Northern California that prior to legalization honestly grew a lot of illegal cannabis. And so it's pervasively used in a way that, having practiced in other parts of the country, I'd never seen. But he was reading about this and then suddenly said, oh my God, I've grown a small baby, my baby's gonna have a seizure disorder, I did it all wrong, right? And part of the reason he had never bothered to share this in the very intermittent prenatal care, I think he'd had 2 visits maybe before this ER visit, was for this reason, in his own words. It was hard enough to show up to the OB office trans. I didn't want to talk about how bad and awkward I felt there, and how much I was smoking, and how much I drank in the beginning of pregnancy. It can already be hard for us to elicit an actual alcohol use history in pregnancy because there's such strong shame. I think that the years, at least in the United States, for many years in the 60s, 70s, and 80s, there were strong campaigns about not drinking during pregnancy, and it's like there's this pervasive sense, we know not to talk about that, but it's not if you're doing toxicology screening, not on a urine drug screen, so it's something we often miss. But particularly for people who identify as sexual and gender minorities, they may be using substances, which we're about to talk about, some of the epidemiology, in ways that are much higher than than people who are in the sexual and gender majority. So one of the things that makes this really difficult is that we haven't spent a lot of time studying or really gathering good data about sexual and gender minorities. In fact, the best data we have in the United States comes from something called the PRIDE survey, Population Research in Identities and Disparities for Equality Study. And what's important about this is prior to this study, and again, 2006 to 2015, we are only talking about 10 years ago, most data that was gathered about sexual and gender minorities was just not straight, right? Or not heterosexual. So we didn't have the really important subtype, right? We started this talk together by me going through all of those different letters. And all of those different letters have their own distinct experience, just like we all do. So the other thing that's important to note is, independent of substance use concerns, we actually know that there's a higher likelihood of poor pregnancy outcomes for people who identify as sexual minorities. There has not been, at this point, sufficient evidence to look at gender minorities and how prenatal care and labor outcomes are different within that population. But for lesbian and bisexual women, they're twice as likely to smoke cigarettes during pregnancy. 30% of pregnancies end in a miscarriage or an intrauterine fetal demise for bisexual or lesbian women, and that's only true for 19% of heterosexual women. There's an odds ratio of 3.24 of having a stillbirth at term, one of the worst things that any of us birth workers experience, one of the hardest kind of deliveries to be present for. Lesbian women are more likely to have a low birth weight neonate. One thing that wasn't in this 2019 study that I think is important to reference is that there is a higher use of assisted reproductive technology, so in IVF or intrauterine insemination, both of which have higher likelihoods of preterm labor, preeclampsia, and low birth neonates. So I just want to honor that there could be some confounding in that. And similarly, there's a higher likelihood of preterm delivery. So when we go back to some of the PRIDE study data, what we see is that in terms of alcohol, lesbian and bisexual women are more likely to be moderate and heavy drinkers. And even when people have access to insurance, and again, this is a study done with American people where our insurance system is complicated, structurally divisive, and is not universal, which I recognize is probably very different than many of the people to whom I'm speaking right now. But regardless, even for people who were American, identified as lesbian and bisexual, had insurance available, they were less likely to seek out particularly higher levels of care like residential treatment. And then marijuana. So there was a 2019 study that found that the lifetime marijuana use is higher for sexual minority women, and also that people who identified mostly as that Q, that queer or questioning, were the most likely to use marijuana. And then cocaine. So interestingly, there was not necessarily a higher likelihood of binge cocaine use across any of the sexual minority subtypes. However, there was a greater prevalence overall in all of them, with bisexual people having more likelihood of using cocaine. One of the things that is most interesting about the PRIDE study is that amongst all the sexual minority populations that were parsed out, bisexual people actually had the worst outcomes. And we think part of that is sort of the double stigma, right? Not fitting fully into a heterosexual world, not fitting fully into a homosexual world, but feeling like there's this kind of constancy of looking for belonging, right? Where will I be included? And then opioids. So in 2019, they found that a sexually minority population had a greater likelihood in the past year of heroin use, and that there was a greater likelihood of seeking out prescription opioids. So why is this? So I want to offer sort of two reasons, and one is from a social scientist, and one is from a neurophysiologist. But this is minority stress theory. Are people familiar with this at all? Has this ever crossed anybody's lens? Okay, so this was created only in the 1990s by a man named Eilen Meyer, and he is a clinical psychologist at UCLA. And interestingly, he was working primarily with gay men in Los Angeles and decided that why in this intersection of public health, so obviously coming out of the HIV and AIDS epidemic, but why are the outcomes so much worse? And what he purported is that when people are not in the dominant majority, there's a downstream burden of stress that they experience. So while this applies, or while it originally applied to sexual minorities, the same theory of minority stress theory has been used to apply to people of color, people of gender minorities, to understand why are they having worse outcomes. But the idea is that there's distal stressors, so things like maybe you are applying for housing and someone sees your last name, or they meet you and they stigmatize or assume that you're gay and therefore don't offer you housing, right? That's a distal stressor. I do really appreciate the fact that this clinical psychologist used anatomy words to clarify his theory. I just love when these things intersect. Or there's more proximal stressors, right? There's the lived reality of perhaps your day-to-day engagements with people actually involve people stigmatizing you, judging, not giving you access to the care that you need. And then I want to offer another theory that became popular in the 1990s called the polyvagal theory. How familiar are people with this? No? Oh my gosh, okay, I see one hand. Well, I am so excited to share this with you because I especially think that as addiction medicine practitioners, this is a large part of what helps us, I think it helps us trick our colleagues, right? People who are already, I think it allows us to use science and to use this theory that was by a neurophysiologist and help people understand why the way we render care is so important. So Stephen Porges is a neurophysiologist, and in 1994, he was at, I think, the University of Indiana, and he wanted to come up with an understanding of what was called the vagal paradox. So I also love this because it's connected to birth work. So monitors, in most countries, external fetal monitoring, right? And there's a certain wavelength that we like. We like to see the heart rate doing kind of what I'm doing with my head in my hand right now, which is called moderate variability. That lets us know that the fetus is getting good circulation to the brain and the heart, the most vital organs. We know that that's a parasympathetic, right, that rest and digest tone. However, if the baby's heart rate has a bradycardia, if it gets really, really low, that's also the parasympathetic nervous system, but that's telling us that we know there's a concern. Baby is not getting oxygen to heart, lungs, all of the parts that are so critically important to maintain oxygenation for during labor. So Dr. Porges wanted to understand why this was. And what he discovered is that there's actually two branches to the parasympathetic nervous system. There's a dorsal vagal branch, and this is the branch we're all familiar with from medical school, right? This is your rest and digest. It's mediating the autonomic function of your SA node, your respirations. It's what's allowing us to digest our breakfasts right now. This has been with us since the moment those fish walked out of the water and became reptiles. Then there's the ventral vagal, so named because these are vagal fibers that come off the ventral part of the spinal cord. And this is newer from an evolutionary perspective. It's shared only with mammals, and this is actually the part of our nervous system that allows for social function. So all of this prosody, all of this musicality to my voice, similar to a kindergarten teacher right now, that is using the social engagement system. Eye contact, smiling, all of that, that is evolutionarily based to help us connect with each other. And what he found when he put this neurophysiologic finding in the broader context of evolution is that our drive to survive is actually rooted for mammals in the longing to connect with each other, in the need to connect with each other, in the fact that we started as migratory tribes, and ideally, if I saw a mastodon coming over the horizon, I would look to my tribe and be like, y'all, what are we gonna do? You got the spear? Okay, great. I've sacrificed you. Adam is apparently going out front to deal with the mastodon. But we go to each other first. And the other thing that's important about this is that there's a hierarchy of response. When we are safe, when we are whole, when our nervous systems are intact, we lean on each other for support. When we feel threatened, so imagine some of the stories that Adam and Taila told. When we grow up in a home where we know we're not safe, where we know that there are relationships that cannot be counted on, when we're existing in the milieu of developmental trauma, we're not safe. I can't lean on this foster parent whom I don't trust, whom I've just been taken away from my birth mother. And this is true even when people are pre-verbal, right? There's a knowingness that we have. When that happens, we're now in the realm of threat. And when we're in the realm of threat, what happens next is that we default into the sympathetic nervous system. And so everybody knows the F's, right? We go into fight or we go into flight. And fight, when you grow up and you're no longer that kid in foster care, looks like anger. It looks like rage. It looks like violence if it's left unmitigated. And flight looks like anxiety. It looks like panic. It looks like leaving the hospital against medical advice when you don't feel safe with the information that you're being given. Now, what happens when those strategies don't work? When your threat is still not met by your fight response or your flight response? When that's the case, the nervous system defaults into the dorsal vagal. So we go into freeze. And freeze is that place of shutdown, it's collapse. I know you all have felt it in the room with people, where they just fully withdraw. So I want to be mindful of time, and I'm going to move on a little bit, but I want to mention this piece. So this was a qualitative study of 12 pregnant patients in a Swiss clinic, or excuse me, in Sweden. And it was a qualitative study that looked at these 12 pregnant persons' experiences. And what they named about the expectations of their prenatal care is that they expected to be excluded and ignored when they contacted the office. They had a strong amount of difficulty trusting the healthcare workers they were working with, in part because, and there's a beautiful part in this study where they quote a midwife, and this midwife, who I genuinely believe was acting in good faith, would consistently say to the trans patients, I'm gonna mess this up, so you're just gonna have to tell me when I'm wrong, which very subtly puts the burden, right, in America, where we have been going through a lot of gyrations around our history as it relates to race. That puts the burden, that's an example of, in this case, gender fragility, but white fragility, right? You know, it puts the burden of proof back on the person to teach and to explain. Now, the ways to ensure that their needs were met were selective disclosure. What that means is that these trans patients actually found that they had to track constantly who's safe here. Who's safe? Who can I talk to? And who can I comfortably share with? And bridging knowledge and power gaps. So, and very briefly, because I do want to have some time for people to just name anything that's alive for them. So I want you to think about 3 different domains where each of us can have a voice, and each of us can encourage agency for our patients and for ourselves. So we've got the domain in the clinical room, we've got in the building, the spaces we practice in, and then we've got the larger systems level work in the world. So in the room, when it applies to working with people who are sexual and gender minorities who also have a substance use disorder, some of the most basic things that you would honestly do anytime you meet someone. Hi, what's your name? What are your pronouns? What do you like to be called, right? It's really just a matter of extending human civility more than having to do a whole new thing or learn a whole new procedure or way of being. Some other things that we can do in the space of clinical encounters: use just the terms for reproductive organs. Talk to the organs like they're an organ. So you're a person with a uterus, you're a person with a penis. Simply use the words instead of having to ascribe them to a larger gender. Also important to make sure that people are comfortable with the vocabulary that we reviewed at the beginning. So part of that is in the room, making sure that all of the people within a clinic infrastructure, right? So from your front office to your back office and your medical assistants, every level of provider, your administrative team, that people are regularly going through and not even just education, but just reminders, right? Like reminders of these are the language that we use as more and more people identify publicly as they shift from an inner orientation, but they change to a public sexual identity or gender identity that differs from the norm. And then what can we do in labor and delivery? So parental heart rate monitoring, educating and empowering nurses. Sometimes that means using terms like chest feeding. There are people who can have had a mastectomy as part of their gender-affirming care and actually can still lactate. I've had one patient who worked really, really hard to make that happen using some galactolog medications and herbs and lots of nipple stimulation, but recognizing that there's pathways to talk about this for gender nonconforming patients. And then postpartum. So the fourth trimester, those 3 months after delivery, the most vulnerable time, right? And actually the greatest likelihood for postpartum suicide, if anybody happens to know, it's 6 months. Right? It's the 6th-month mark. And what's important about that in an American healthcare system is we decide the postpartum period is done at 6 weeks, which I think everyone here who has been involved with a parenting person knows that 6 weeks, you're maybe just beginning to remember your name and shower more than once a week, right? Like that's really where you're at the 6-week mark. So it's important to recognize for those of us who are actually taking care of patients that even if our insurance guidelines are like, cool, that was your postpartum visit, see you later, the postpartum period arc is longer. So I just want to say thank you so much for all of your time. We are right at time. We have a minute or two, but if there's anything that you'd like to share for any of us, I'd like to invite that now. I think we have some mic runners.
Thank you, and we would like to invite any questions or comments.
Hi, I'm Jess Wilder. I'm a family and addictions medicine doctor on Vancouver Island. We have a lot of spillover from the downtown east side in Vancouver, so quite a severe opioid use disorder prevalence in our city of just over 100,000. I mainly do a lot of street medicine, but in our hospital we also have a harm reduction and stabilization unit called Cedar Circle. And a struggle that we very frequently encounter is interactions with MCFD, which is our Ministry of Child and Family Development, the inconsistency of how they approach different situations, as you've alluded to, patients with money versus patients without money, patients who are Indigenous versus patients who aren't Indigenous. We have wildly different outcomes for these different families. And I'm curious if any of you can speak to your experience of trying to work with these organizations, because we've been trying to build bridges and trying to find some ability to collaborate more effectively and work together in these cases. And I'm wondering if you've found a way to do that, or if lawyering up has kind of been your approach.
Yeah, sure.
Thank you for your question. I think that's an excellent point. When we first started, we did not have collaboration. And so we actually had the opposite happen. Our child welfare agency asked the hospital to delay making a referral to our clinic until they were able to speak to the parent alone. And so that left a bad taste in the hospital's mouth and accelerated the referral process for us. I would say the success we've had is engaging a different level of the organization. So instead of the line social worker who is coming out, maybe higher up organizationally, and then having basically a different level of cooperation. So we have then, after a year, cemented a partnership at the highest level with our child welfare agency. And so even within that agency, there is a whole bureaucratic chain, and I think who you're contacting there is important, having somebody that you can reach out to when there are complications on the ground level, because the policy of that child welfare agency is not to have this widely varying outcomes. It is to maintain some semblance of normalcy, and so having someone that you can reflect that back to and say, these are the challenges, that's where we've seen that cooperation be fruitful. If that helps answer your question.
I would add to that, having family educator, if you have a service that can start the process on patient submission, sometimes could be very helpful to be able to offer resources to allow people to know that they have options and choices. Anyone else? Well, at the end, we would like to finish by also practicing gratitude with you and thanking you for being here. As clinical providers, health professionals, we try to empower our patients with wellness. So I would like to finish our symposium by inviting all of us to practice wellness together and to share with you a mindfulness exercise that I call Lovey, dedicated on my Lovey family. And we practice it together, so it's going to take a minute. I'm going to invite all of you to stand up. Thank you. And if you can make a few steps and feel the ground, when we encounter challenging situations in daily life, we need reminders of our integrity, foundation, and values. So feeling the ground is a really good way to do it. And now spread your arms as far as you can. And look in front of you, because with our care, we try to empower our patients to have a lot of options, choices, and to look ahead. So look ahead of you. This is your horizon, and it's open in front of all of you. Now spread as high as you can until you feel uncomfortable, because growth is not comfortable. And that's the beauty of it. All of us are learning together who we are, supporting our patients. And now give yourself a hug, because love, compassion, appreciation for who we are is what grounds us to be there for our patients, meet them where they are while appreciating who we are. Big gratitude for all of you. Thank you for being here today.